The feds, provinces, and territories continue to increase healthcare spending, many say at an unsustainable rate. Yet it seems that wait times for medically necessary procedures are not generally improving. Is there a way to change this? Today's guest may have a few suggestions. Bacchus Barua is the Associate Director of Health Policy Studies at the Fraser Institute in Vancouver. Welcome back to Bridge City News, Bacchus.
Thanks so much for having me on the show again.
I see that the study found on a per capita basis, Alberta's provincial spending ranks second highest in Canada, but in performance, we don't seem to be getting the best bang for our buck.
Yes, Alberta's story is really very much like Canada's more generally. Canada is a very, very high spending country compared to other systems with universal healthcare. But in terms of performance, we just really don't see it. We're usually in the middle of the pack when it comes to physicians per capita. We're usually in the middle of the pack when it comes to nurses, outcomes, things like that. And actually quite poorly when we look at an international scale when it comes to the resources. In Alberta, we find a very, very similar story where Alberta is the second highest spender per capita. It's consuming 40% of its budgets. And yet when it comes to physicians per capita, it's middle of the pack, nurses middle of the pack, CTs, MRI scanners middle of the pack. So there's a problem between the translation between what's being put into the system and what's actually coming out of it. And I think what we see most clearly is when we look at wait times. Alberta had a wait time of 26 weeks between referral to treatment last year, which shows you that there's a lot of rationing going on in the system.
So how long would it take for somebody in Alberta to get a knee replacement or even get an MRI done?
Well, this particular study doesn't look at that. We look at that in our wait times studies. In general, when we're looking at 12 different specialties, which is looking at things like orthopedics, as you mentioned, but also things like gynecology, internal medicine, and so on and so forth, the wait time was 26 weeks. And just for some context, when we started measuring the wait times in the early 1990s, the wait time was only 10 weeks in Alberta. So this is a consistent deterioration that we've seen in the province right across the board.
So a lot of solutions for many of these politicians is just throw some more money at it, and that'll take care of the problem. But usually when you do that, that means higher taxes. How well has that worked out so far for us?
Unfortunately, Alberta for a very long time has consistently increased its spending far above the rates of what otherwise would be sustainable. And I think we're seeing it now when revenues are not coming in quite as much, it's starting to have to tighten its belt. But this has been a very, very old and long problem where politicians have tried to solve the wait times issue, tried to solve the rationing in our healthcare system by throwing money at the problem, and it just doesn't work, and that's what we see in Alberta. Fortunately, there are, however, a lot of policies that the province can pursue well within the confines of the Canada Health Act, and some policies it should also look at which do go beyond the Canada Health Act, which is a significant barrier for provinces when it comes to experimenting with policies that are routinely used in other countries with universal healthcare. And that's what this study is really about. We're looking at what can Alberta do in terms of policy to actually tackle the problems that it's facing currently in its healthcare system.
Now, you make some suggestions as to how Alberta can get better results. We need to expand capacity and create more competition among private providers. But that's a word that sometimes scares people, Bacchus, private.
Well, let's start with some of the basics. When we think about universal healthcare in Canada, we unfortunately have a tendency to only think about it as a government healthcare system. That's simply not the case. When we look at other countries with universal healthcare, and yes, there are several other countries, 28 at the last count that we did with universal healthcare, they usually provide it through a combination of public or government financing and delivery, but as well as private not-for-profit, as well as private for-profit financing and delivery. And most of these other countries, I'm talking about, countries like Switzerland, the Netherlands, Germany, France, Sweden, and Australia, they understand that it's only through working together with public and private delivery systems and financing systems that they're actually able to deliver better care on universal terms to patients regardless of ability to pay.
So using third-party private clinics to provide publicly funded healthcare services is not necessarily illegal, is it?
Well, we actually have good evidence in Canada to show that this does work. It doesn't actually contravene the Canada Health Act at all. Before I get into the legality, let me explain maybe a little bit about the Canada Health Act. I think a lot of people think about this as something about something that defines the rights in terms of the healthcare system, but really it's a financial tool. It's simply an instrument that dictates how federal funds are transferred from the federal government to the provinces. And if the provinces don't meet the requirements according to the federal government of the day, then the federal government withholds cash funds. Now, some of these things are absolutely clear in terms of what the province can and can't do. So things like cost sharing and co-payments within the public system, there are very, very clear terms in the CHA that says that provinces will incur a financial penalty. But there are other terms that are far less clear and much bigger and open to interpretation, and that actually creates quite a lot of an issue in terms of what provinces can and can't do. So you have a lot of hesitation with provincial governments. But one really clear example that we can see is the province of Saskatchewan. Saskatchewan went from having some of the longest wait times in the country in about 2008. I think the wait times was about 28 weeks at that time, to currently actually having the shortest wait times in the country of about 15 weeks. Now, it did a combination of different things through its Saskatchewan Surgical Initiative, many of which are at the hospital level. Some of which are, more common sense things that we will see as we have a higher integration of technology in our healthcare system. So, for example, a centralized pooling system to pool referrals, which just generates a lot of efficiencies in terms of the referral system. But what it also did was it did actually contract out services to third-party private clinics. And they were able to do it at a cost that was actually 26 or 27% lower per procedure. And what it does is it massively managed to expand capacity, create a lot of competition within the system. And we see the results. The results is that Saskatchewan today actually has some of the shortest wait times. There's no contravention of the Canada Health Act. This is something that Alberta has actually already experimented with in the early 2000s. But there's a long way to go. There are a lot of prohibitions within provincial legislation that could be taken out that will actually help it be, or rather blossom into the sort of competitive system to deliver services to patients that it really should be.
Now, you say Alberta law requires all major surgical procedures be delivered in a public hospital, but that should change to allow for private hospitals to provide surgeries?
Well, the legislation is very specific in terms of, what qualifies as a hospital as opposed to what qualifies as a clinic. And this is really just, it creates a lot of ambiguity and uncertainty about what can and cannot be done. I think there's a lot that the province could do in terms of just clarifying the legislation, making it a lot simpler to say that, okay, if a private facility that already exists is able to deliver services that are publicly financed by the government, and can add to capacity, then it should be allowed to do so. If there's a patient who's waiting for treatment, and if there's a private facility that's able to deliver without actually needing to hire extra doctors or build a new building, then they should just be allowed to do it. Allow the system to actually work. But this of course is just one of the things that would hopefully help improve Alberta's healthcare system. And I would say in some ways it's a band-aid fix because, for example, at best we can imagine that maybe Alberta's, things like this would help Alberta's wait time come down from 26 weeks to the 15 weeks that we see in Saskatchewan. But, this is nowhere near what we see in terms of wait times in other countries like Switzerland, Germany, and the Netherlands. They often have wait times that are just a few weeks or no wait times at all in some circumstances. And once we get into the systems that are in place in those countries, that's where things get a little bit more difficult. But there is a lot that Alberta can do well within the confines of the CHA.
So does Alberta need to change the way it funds hospitals? Apparently activity-based funding results in improved quality and reduced wait times. Can you explain to our viewers how that works?
Sure. The current system of funding that we generally have in Canada is what's called a system of global budgeting. And essentially, hospitals have a set budget based on the population that they serve, and they have to work within that budget because there is only one funder, and that's the government. Now, what this does, however, is it tends to make hospitals treat patients as a cost to the system that's eating away into the budget. Most other countries over the last 10, 15 years have switched to what's called an activity-based funding model. And what this does is it actually is a system where hospitals are paid according to the number of cases and the types of cases that are actually being delivered in the hospital. So the incentive over there for the hospital is to actually treat more patients. And importantly, if there are two hospitals and a patient needs to go to one of the two, it'll actually create competition between those hospitals because they would actually get funds if they actually treat the patient. Whereas over here we have a system where essentially the incentive, although I'm not saying that hospitals would necessarily do that, but the incentive is for a hospital to actually have a patient, a very expensive or complex case patient, go to a different hospital because it'll eat into their budget. So that's just one of this, one of the interesting things. And I think, especially again, if you add that to the third-party private providers, that would create a very robust competitive environment where to the patient, it really shouldn't matter whether it's the hospital is owned by the government or whether it's a private for-profit facility or not. For the patient, all that should matter is that they are getting treated in a timely manner. And these are two things that can help that actually happen.
So if we created a centralized surgical registry and started pooling referrals, you believe that would improve efficiencies?
Well, that's definitely one of the things that Saskatchewan did. Currently, we have a system where, like many other countries, when you go to your family doctor and need to get treatment, you are first referred to a specialist. Now, what's happening right now is that the family doctor does not have complete information about all the specialists in the province, what their wait times are, who has the shortest wait list, and the patient has very little choice in terms of that as well. Alberta's done a good job in terms of updating a lot of that information over there, but really this seems to be, or at least what Saskatchewan did, is a system where all the referrals go into a centralized pool, and patients are given the option of having a consultation with a specialist with the shortest wait times, while retaining, of course, the right to wait longer for a specialist that them or their family doctor would rather prefer. This is one of those things which is, I call it a little bit of a no-brainer, but it's one of those things that will improve efficiency. It'll do it at the margins, but it's certainly, again, when we're talking about something like this, there's no issues in terms of the Canada Health Act or issues like that. It's something that Saskatchewan has done, and I think Alberta is probably moving towards it already. It's got a couple of small pilot programs, but it would certainly improve efficiency in the province.
So does federal law allow provinces to let individuals use private insurance or maybe pay out of pocket for a doctor to deliver medically necessary services?
Now, here's where things get very, very difficult. The key issue with the Canada Health Act is the issue of hospitals that are sharing the cost, or insurance that shares the cost with the public system. When the costs are shared with the public system, then the central tenets of the Canada Health Act become very, very specific in terms of the penalties that the province will incur. However, for example, if we take an extreme case where you have a private parallel system where everything is insured completely, everything is paid out of pocket, there's nothing really in terms of federal legislation that's preventing that from taking place. It's really actually, it starts to become provincial legislation that's currently hampering that. But my understanding is that a lot of that provincial legislation came in because of the ambiguity in the federal legislation, which leads to a situation where you might have the government of the day suddenly decide that perhaps that's impeding reasonable access, or this could possibly maybe result in some sort of a two-tier system or issues like that. And it's really that ambiguity that causes a lot of issues. But in terms of the actual legislation, if things are fully privately funded and delivered outside the public system, there really shouldn't be any issues.
So Bacchus, let's talk a bit about dual practice, which would permit physicians and other healthcare professionals to work in both the private and public sectors. Is this currently legal in Canada and in Alberta?
Well, this is something which, interestingly, there's no federal restrictions on it. However, again, there are many of the provinces have either direct things impeding this from happening, or have disincentives. Alberta is actually pretty good about it, but the thing is, everything else, when it comes to what it restricts in terms of private financing, in terms of the rates that physicians would charge in the two different practices, in terms of what surgeries can actually be delivered in the two different cases, leads to a situation where it's essentially a status disincentive for physicians. And I think with dual practice, one of the things that we have to remember is that while a lot of people might be afraid that it might result in physicians moving away from the public system to the private system, it's only if you actually restrict dual practice that might actually happen. However, if you actually allow it and actually encourage it to happen, that would result in a system where these very scarce and very skilled resources are being used as efficiently as possible. If the public system has only enough money to compensate them for a certain amount of time, I think they should be allowed to actually also go to the private system and deliver those services for patients in that need.
A controversial suggestion to improve healthcare is cost sharing. the concept of requiring patients to pay for part of the healthcare service. Can you explain how this would actually work?
Sure. Cost sharing is something which, contrary to I would say a lot of popular perception, is actually the norm in other countries with universal healthcare. They of course do it in very different ways. For example, you see the most extreme example in a country like Switzerland, which actually, I should say, spends only a little bit more than Canada, but it has far more resources, far shorter wait times, and still has a robust universal healthcare system. In Switzerland, you have a system where essentially everybody is mandated by private insurance. You are required to pay premiums. If you can't pay your premium, you're given a subsidy and helped along with it. But you also have co-payments that are required. So patients usually are expected to pay a deductible, let's say somewhere between $300 to $500. After that, they're also expected to pay 10% of the cost of their treatment, but there's an annual cap to ensure that it's never more than a certain amount. So, for example, you could say $1,000 or a certain percentage of a person's income. Now, we find various different examples of that in other countries. There are some countries that only have the co-insurance, some countries that only have the deductible, and the rates, of course, vary. And how it would actually be implemented would be up to Canadians, would be up to Albertans. But I think it's important for us to remember that this is a fundamental and very normal part of other countries with universal healthcare. It helps patients remember that these are scarce resources that need to be used responsibly. It helps triage correctly to ensure that patients are not misusing things like emergency room departments. And if designed right, and of course it should be, great care should be taken to make sure that it's designed right. It's never intended to be a financial burden. It's never intended to be a situation where patients are choosing between healthcare and their mortgage, but it's meant to just make patients think twice about what's actually happening. And importantly, it needs to happen in conjunction with things like private provision, needs to happen in conjunction with things like activity-based funding. All of these things play off each other, and they're all things that are very commonly found in other countries with universal healthcare that do universal healthcare better with shorter wait times.
Bacchus Barua, the Associate Director of Health Policy Studies at the Fraser Institute. Thanks a lot for joining me today from Vancouver.
Thanks so much for having me on the show.
On behalf of all of us here at BCN, I'm Hal Roberts. God bless. Have a great night.